So I want to introduce Dr. Monica Jain from Cedars-Sinai. She's an endocrine and general surgeon. She's the director of surgical innovation as well for Cedars-Sinai, and then she heads up a human factors lab with a crew of people to really push what we think of today as human-centered design into a whole nother level. I've been a medical device guy for 15 and a half years. Every time I say this, it goes up a little bit, and then I have to rue the fact that I'm getting older. There are a lot of medical device companies, I've been a part of them, who believe they do human factors. And I think what Monica and her team at Cedars-Sinai are doing is really, testing the truthfulness of that. When they do work with companies, they bring these companies in and then they say, hey, look, if you can survive, getting criticized by the folks at Cedars, and they will tell you what they really think about your job on human factors, you will actually have done a really good job of human factors. She's got folks who have PhDs from aerospace on her staff, and the relationship there is that there's cognitive loading is a big deal when you're trying to not to kill 300 people in the plane, or because you're trying to save your own life and in the war theater. So, that's not always an obvious connection, but I think it's something that's really, really critical. And so I'm really, really pleased to have Monica here. She's also a venture partner at the Wavemaker 360 Health Fund, which is just down the street, more or less. It's on the lake. So anyway, would everyone please put your hands together for Monica?
Um, are we connected on the Zoom because it told me that I'm not connected to a what?
You've been disconnected from the Zoom. Don't worry about it. Speak into the mic. We've got the webcam. Well, if you pop back on, great. If not, we won't worry about it.
Okay. Hi, everyone. Thanks, Evan, for that kind introduction. As he said, I'm Monica Jain. I have a passion for human factors. Just to provide a little bit of background to myself, I did my undergrad in biomedical engineering. I come from a family of engineers, and so I think it was built into my blood that I always wanted to work on innovation and engineering and design. From biomedical engineering, I actually loved working with people and on the human side of things. And so I transitioned into medicine, went to medical school, and then went into surgery, really hands-on, not following a pattern here at all. After that, went focused on endocrine surgery, have been practicing endocrine and general surgery for the past several years, and also got expertise in human factors, do a lot of work for startup companies, and have a human factors lab at Cedars where we do some interesting work there as well. I've been working in the innovation space for a long time as well. Since I've been in residency, I did my residency at Cedars-Sinai, so I've been there officially last month for 10 years, which is exciting. But I've been in the innovation space, do a lot of work with startups, do mentor for accelerators, do consulting, and then as Evan mentioned, also some human factors work for startups as well. So I'm just going to go a little bit into the background of human factors and talk a little bit about, see if I can manage all of this together. There we go. All right, so first, just talking about a definition of human factors for those who are not familiar with the field. So according to the International Ergonomics Association, which is one of the big associations that's focused on ergonomics or human factors, it's the science of investigating the interactions between humans and other elements of their work systems. And so looking at those interactions through theory, principles, data, and methods, they work to optimize human safety, efficiency, well-being, and overall system performance. And human factors engineers really focus on the design of the system to optimize the way that humans work. They're not trying to change the way that humans work themselves. And they try to fit the environments to the needs, the abilities, and the limitations of the people that are working in that system. So there are some key terms that we use in human factors that I'll talk about. Usability refers to how well a specific user in a specific context can use a product to achieve a defined goal. User experience involves the emotional response or the connection that you want to achieve between a user and a product. And I have a user experience person here, so you can correct me if I'm wrong, but that's how we look at user experience. And then human-centered or user-centered design is a common method used by human factors practitioners to create the systems that prioritize ease of use. And so it really involves an iterative process where concepts and prototypes employ user testing to inform the design of the device or the system. So a very short journey on human factors. I'm going to skip through some of my slides because human factors has actually been around for a very long time. But I do like to point out that human factors actually originated in 430 BCE in ancient Greece with Hippocrates, where he was actually applying human factors principles in his work as a surgeon. And he proposed that a surgeon's performance could be improved based on concrete recommendations for the workplace. So he suggested that posture, sources of light, instrument location, and the size, weight, and shape of a surgical tool can influence a surgeon's performance in the operating room. And so even from the very beginnings of human factors, there's been a tie between human factors and healthcare, and specifically surgery. So I'd like to kind of point out that these important concepts like usability and occupational biomechanics really originated in healthcare, and although went away from healthcare for a long time, are fundamental to the way that we work in healthcare. So quite a bit later, Frederick Winslow Taylor, who's a mechanical engineer, worked in industrial efficiency and worked on designing different shovels for work that was being done in a factory where everyone was using the same shovel and having difficulty with digging dirt. And so instead of having all the workers have severe back pain, by designing these different shovels that you can see over here, he was able to optimize their work and improve the efficiency, decrease the physical strain for all of them, and significantly increase the amount of work output that they were able to perform. And then Frank and Lillian Gilbreth became a disciple of this Taylor system in industrial efficiency. And they both kind of were obsessed with ways of finding the most efficient way to do something. And they might be familiar to you if you've seen the movie Cheaper by the Dozen. Frank and Lillian Gilbreth were the parents who were experimenting on their dozen children with ways to optimize efficiency in all of the work that was done. So they did a lot of work in bricklaying and then moved also into healthcare, where they worked with surgeons to reduce fatigue and optimize work. And so they would video record surgeons and then see how they could optimize the layout of the operating room to minimize the amount of movements across the operating room and improve efficiency in that space. And then I'll just skip through some of this to move forward, but I think it's important to talk about the Swiss cheese model, which we see a lot in healthcare and specifically in quality improvement in healthcare, but it is an important human factors component where we looked at the concepts of active and latent failures, where active failures involve errors that are committed by the users of the system, and latent failures are breakdowns at various levels of the organization. So for example, if you have inadequate procedures or poor equipment design, those are latent failures. And when all of these may build up, or you have active and latent errors occurring, you can have serious adverse events that occur. And so it's very important to design the system to minimize the number of latent failures so that even if an active error occurs, we can minimize the effect on the system, on the patient, on whoever is in that work system. It's also very important to avoid the culture of blaming users. This was a big deal in healthcare, especially also in aviation. There are a lot of improvements made in the culture in aviation to not blame the people who are working in the system, but actually think about how the environment was designed such that you could improve the design of the environment to reduce the number of errors. And so this is an example of human factors in medicine. This is one of the earliest applications where PCA pumps, which are infusion pumps for different types of medications, were redesigned based on the input of nurses who are using the system in order to significantly simplify the interface from the left to the right, in order to have fewer steps to accomplish the same task, increase the usability and ease of use, and therefore decrease the number of errors. And so faster time completion, fewer errors, and lower subjective mental workload with just redesigning the pump to understand how nurses were thinking, interacting with the system. And they especially, importantly, I think in this, use very inexperienced nurses and nursing students so that they could try to work on the people who are least familiar with this device and really optimize ease of use and usability, even if you were new to using that device. So after some of these seminal studies, organizations really started to value human factors in healthcare. In 1999, To Err is Human was published, and that's a really big publication that said that most preventable adverse events are not related to poorly performing nurses, physicians, etc., but are related to issues with the system itself. And so this was really bringing human factors to the front in healthcare and telling people to optimize the design of the system and design of the environment in order to minimize errors in healthcare, of which so many are preventable. And so these human factors concepts really then came into being in healthcare, and this then had an effect on expansion of human factors in healthcare using a holistic systems design approach in a lot of different fields, including the design of the devices that we use, designs of the environments that we work in, such as the nursing stations and the operating rooms, as well as services that met the needs of the clinicians, staff, and patients. And also, it pushed the FDA to think about human factors when it's looking at devices to approve them for use in the United States. And so in 2011, the FDA issued an update to its regulatory approval guidelines, which was the first update in 10 years for the FDA, to include a very rigorous human factors evaluation process when they're evaluating these devices for approval for use. And so they're very prescriptive in defining how the product usability testing would occur and how final design validation would be ratified to ensure minimizing errors and optimizing safety. And so I'm going to take you through a few examples of my work that my colleagues and I have performed in human-centered design in healthcare. My biggest project is related to robotic surgery. We're funded by numerous federal and industry grants, and we focus on studying efficiency and performance during robot-assisted surgery. So robotic surgery involves robotic instruments that are controlled at the bedside by a surgeon who is sitting away from the robot at a console. So that surgeon is no longer sterile. They're at a console away from the field, and the robot arms are being controlled by the surgeon at that single console. And there's up to 4 arms that are used, usually at least 3 or 4. Sometimes there's an assistant at the bedside, but generally this allowed for I don't know if allowed for is the best word, but allowed for the surgeon to be separated from the patient, allowed for kind of more distinct haptic control of the instruments, and allowed for kind of different configuration of the operating room. So there are some pros and cons. It has been touted to improve patient recovery, improve surgical outcomes, improve visualization, dexterity, tremor reduction, and ergonomics. But in fact, a lot of our research from people around the country has shown that there's a question about whether it really improves patient recovery. It's pretty similar to laparoscopic surgery. The incisions are the same and the overall operation is usually the same. Improved surgical outcomes have only been proven out related to prostate surgery and have yet to be proven out in the many other applications of robotic surgery in healthcare. And the biggest thing is that they say that the surgeon is better off sitting down at a console, not using instruments with their arms in odd positions. But really, we've seen that up to 80% of robotic surgeons actually still experience significant physical discomfort or ergonomics from being in a console where their head is bent into the console. They may be slouched in the chair, and they have increased work that's required from their fingers rather than from maybe their upper arms. So it's just a transfer of the physical pain that they may be experiencing, and there's still some poor ergonomics associated with robotic surgery. It's also high cost, high technology, which significantly increases the cognitive workload, not necessarily for the surgeon after they've been trained, but for the operating room staff, especially if that staff is not consistently working in robotic surgery and understands the technology, how to position the robot, how to fix any errors that are occurring in the technology. And then there's also altered team dynamics. As you can see here, the surgeon is embedded into this console. The first few iterations of this robot actually did not include any way for the surgeon to communicate with the team. So they had to build in a microphone into the robot console that then projected across the operating room so that the team could actually hear and interact with the surgeon, because otherwise there was no situational awareness, couldn't understand what was going on. The surgeon is separated from the patient at the bedside. And so all of these things made a big difference in how the OR team was functioning. And then there's also obviously significant physical changes to the operating room environment with a bunch of cords on the floor, increased risk for injury to staff. There are many differences with robotic surgery. So it ends up being a great test bed for understanding human factors in healthcare and how we can optimize the system. So I'm just going to go through some of my work. So we look a lot at flow disruptions, which are disruptions in the natural flow of the operation due to issues with communication, equipment, distractions, things of that nature. And so here is just an example of some studies that we've done on flow disruptions. I apologize, the colors aren't showing up, but basically looking at the different phases of an operation, and that there can actually be a lot of disruptions throughout the course of an operation, and they're different in the different phases of an operation. So before the operation actually begins, a lot of coordination and communication issues, and then during the actual operation, a lot more equipment issues, surgical task considerations, training interruptions, things of that nature. And so we're able to use this data to focus on different phases in the operating room and try to optimize efficiency. And so some of the work that we've done involves training in order to help with OR staff understanding of the system, and work on team training in order to minimize coordination issues and technology issues, at least in the very beginning of the operation when that's the most intense. And we also have pushed the institution to have robotic surgery OR teams that are very trained in robotic surgery, so that those are the ones who are performing those cases to try to optimize efficiency and reduce errors. And then this is looking at actually room size and how room size affects flow disruptions in robotic surgery. Obviously, a lot more equipment in robotic surgery, have to add the console and the robot, in addition to everything else that was already in the crowded operating room. And you can see that the smaller room size to the left leads to significantly increased flow disruptions. And so just increasing the room size, giving everyone a little bit more room to move around, makes a big difference when it comes to how your operating room team is able to function. We're also doing a lot of work on ergonomics in robotic surgery. So we have these great systems where we can look at how a surgeon is sitting at the console and calculate their neck angles, their back angles, their arm angles. And you can see here, this is one of my residents that actually his positioning and posture is very poor. He is slouched. His arms are up in the air instead of 90 degrees. His legs are angled, not at 90 degrees to the ground. So all of this could be optimized, but there's no real ergonomics training for robotic surgery. And so that's a program that we're developing now to optimize ergonomics, to minimize physical issues during musculoskeletal issues during robotic surgery. And then some new work that we're doing on cognitive strain in robotic surgery, which is really interesting. I know this is very small, but just looking at this big peak in the middle here. So this has to do with sympathetic nervous system function. And when your sympathetic nervous system goes up, it means activity goes up, means that you're very stressed. So this big peak in the middle here is when, I don't know if you can read this here, that the surgeon is yelling at the anesthesiologist to make some changes in the operating room in order to optimize what needs to be done for the patient. And down here in this little bar over here, the surgeon left the operating room for a little bit to get a drink of water, go to the bathroom, something like that. So much less stress. And so there is actually a very distinct correlation between the sympathetic nervous system activity and what is going on in the operating room. And so we're trying to correlate the actual activity in the operating room, continuous data, continuous observations to understand how we can optimize surgeon cognitive load, surgeon stress, and actually the entire team, because we have this for the circulating nurses, the scrub techs, the anesthesiologists. And so it can get a lot of data about cognitive load and stress in the operating room. And then I'm going to take some time to talk about some medical devices. So here, talking about human factors, evaluations for different devices. These are just some of the devices that we've done some testing on, some good, some bad, some software, some devices. I really actually want to talk about this third device over here. It's from a company that was bought out by Stryker, previously called Gauss Surgical. Some of you may be familiar. It's a blood loss monitoring device for the operating room. And I think that it's a very interesting device when it comes from a human factors perspective. So what it does is, well, I'll go back and say that in the operating room, generally we estimate blood loss. We don't ever have a quantified way to say what the blood loss is. And so it's a surgeon's gestalt to say what the blood loss in the operating room was, and partially has to do with the patient's hemodynamics and things in the operating room. So this device uses the sponges in the operating room that you hold up to an iPad, and it can quantify the hemoglobin in that sponge and give you quantitative blood loss. Okay, so there's a few things about this device that I'm going to talk to you about. The first thing is that it interrupts the workflow for the circulating nurses in the operating room. Okay, right now the sponges are just discarded to the side. At the end of the case, all these sponges are collected and counted, but nobody has to sit there and hold it up to something and quantify this and do that throughout the course of the operation to understand how the patient is doing. And so this interruption in a nurse's workflow, who's already very overloaded in the work that they're doing, makes a big difference and reduces the ability to implement such a device in the operating room, where the benefit is really only seen in very few cases, because if the blood loss is low, there's no effect to the patient's physiology. You're not going to make any differences in what you're going to do in the operating room, such as transfusing blood, which is really the only thing you would do, or get some more fluids. Versus if there's a lot of blood loss, you know that there's a lot of blood loss. It doesn't matter what the quantity is, you have to deal with the patient. And so there's very few cases that fall in between that where this actually makes a difference. So another issue when it comes to the use of this device and where it can actually be beneficial. So I think that those are some important points to consider for medical device companies, to look at the use case and the implementation. And I'll go into a little bit more detail about that in just a minute, to talk about how we can evaluate workflow and understand how implementing a device into someone's workflow can significantly affect the adoption of your device because of the interruptions in their standard workflow. This company actually did very well because they were able to change their use case to be used in OB. And in OB, there's a law in California that you have to quantify the amount of blood loss that occurs during a delivery. It is a law that is there to help mothers who are delivering prevent any adverse events, especially related to blood loss, when it's very difficult to quantify between the delivery, the placenta, etc. And so this device applied in that setting, where there is a law that blood loss has to be quantified, in a setting where the quantification of blood loss makes a big difference in the outcomes for that patient. They were able to then find success in that field, and then we're a successful company. So we perform our studies at the Cedars-Sinai Simulation Center. It has exact replicas of the patient care settings that we have in our actual environment. to the point that if we have a disaster situation, we can use the operating rooms in the simulation center as real operating rooms for patients, in addition to the critical care rooms, the OB rooms, the ICU rooms, etc. They're all fully functioning and licensed for patient use as necessary. And so again, talking about the implications for innovation, design, and evaluation, it's really important to focus on the needs of the users. What is the reason that you're designing this device? Who is going to be utilizing that device? What is their workflow? And understanding the actual user of the device, not just the patient who is going to be helped by having an innovation in that area, makes a big difference, because the majority of medical devices that are designed are to improve some sort of patient outcome, but they are applied to be used by a clinician of some sort, a surgeon, a physician, like an outpatient physician, a nurse, a scrub tech, something like that. And so there's a difference between the patient and the actual user of the device. And so doing analyses of the actual users, doing customer discovery makes a really big difference in these situations. And in software design, there's a lot of focus groups and initial testing and evaluation that can make a big difference when you're designing the software for usability, decreased cognitive load, and ease of implementation into the workflow. And this is an example workflow evaluation to look at how this is from, I believe, UPMC, and this is one of the clinics, and looking at how they look at patient-reported outcomes. And so there's many stakeholders in this process that you can see over here, where the computers are actually implemented, what functionality they have. All of this makes a difference in terms of whether your device or software can actually be implemented effectively into a system and will be adopted. And I will say that physicians, especially surgeons, are very fickle. And so if you get to them with a device that's not easy to use, that's not something that's going to immediately be effective, they're going to shut it down. They're going to get rid of it. And it doesn't matter how much you fix it. Over time, it's going to be very difficult to win them back. So doing all of this work very early is very important. And that's what I like to focus on, especially when I'm talking to startups. And then finally, medical device design, really easy to be at the prototyping stage, get a lot of user feedback from a lot of different users in order to be able to get to a design freeze where you've actually done a lot of work that will lead to better implementation and adoption. And specifically, something that I love to hound on is that actually now 50% of the medical industry is women, physicians specifically, and a lot of surgeons. And the surgeon demographic is changing specifically. And so the large male hands with increased grip strength that we used to see in surgeons is no longer there. We have a much more diverse patient population, overall average smaller glove size. We're doing some work with some of the societies that I work with to evaluate the new demographic of hand size and grip strength so that medical device companies, when they're designing devices for the operating room, such as staplers and other instruments, laparoscopic instruments, for example, can actually understand this a little bit better, in addition to the general ergonomics of using an instrument. And so the last thing that I want to go into is just that I want to mention to you all that Evan had mentioned earlier is our Cedars-Sinai Insight Lab. This is my human factors colleague, Dr. Tara Cohen, who Evan had mentioned has a history of a PhD in aviation and moved into healthcare. And also my other colleague, Dr. Ed Safarian, who is the Chief Patient Safety Officer at Cedars-Sinai. So we have human factors, innovation, and patient safety all together in our lab to optimize, to do training, assessments of devices and software and research in these areas. And we have significant outreach and impact. And we explore many different issues, and we're available here. I'm gonna push through here. So you can contact us. You can see some of our work on our website, or a lot of our work on the website, and all of our publications and things of that nature. And if you have any questions, or you'd like to consult with us, if you'd like to get trained in some of these various areas that we do. We're doing a training for another university just next month in human factors and really trying to understand how it applies to healthcare. Or if you have a medical device or software company that you want to do usability testing, we're here. You can contact us and I'll take any questions. Thank you.
Thank you so much, Monica. John's going to come around with the mic.
Should I just go walk around with this mic, or should we just have people come back? Either mic. Okay.
So, Monica, stick around a little bit after to deal with or meet some people. Keep right now to questions. So that means a short sentence with a question mark after it. Any stories or comments, feel free to come up and speak with her after. John, go ahead, lead us off.
Okay, this is a pretty long course, so I think I can get around. So is there anybody that has a question for Dr. Jain?
I actually have one, John.
You do have, okay. Let me bring this mic over to you.
I love the piece where you were showing the feedback on the stress and how that helped indicate the what was happening at that time. Have you ever heard of any software companies in their UX research when they're working with customers to work through products using that same kind of feedback?
I have not. I actually do a lot of work with humans in space. And so in space testing, they have a lot more, many more for their astronauts. And so they'll put astronauts into isolation, they'll put them into different tests, and they'll use heart rate variability monitors and heart rate and respiratory rate, sweat, temperature monitors to evaluate how they're doing. But when it comes to software testing or medical device testing, I actually haven't seen that applied in that way. We don't have a ton of data on the application in devices in those settings, but a lot of the data that we have is drawn from the aerospace industry and the aviation industry and things like that. So I think it's a really interesting concept and something that we could consider. It's very easy to put a heart rate variability monitor on someone. You could even use a Fitbit and just see what their cognitive load looks like when they're using the software, where they get hung up, even if they don't tell you that they're experiencing stress at that point, that you can get objective data that there is stress occurring at that point that they're utilizing that software.
Thank you.
I've got a question for you.
Mm-hmm.
So a few years ago, we had a speaker that came to Friday Coffee Meetup, and it was actually a startup at USC. And they were developing a robot for the elderly, and in particular to help them with their exercises, physical therapies, and things like that. One of the things that, going back to your human factor part of your talk, one of the things that they noticed is, as opposed to the robot giving the patient instructions, they reversed it. And so now the motions of the patient was controlling the robot, and they felt that that had a much better outcome as opposed to the other way around. But my question to you, though, is do you see that as being an issue going forward as far as a human interaction? Because as you mentioned at the beginning of your talk, you became a doctor because of that human interaction with the patients. Can you talk about a little bit about that concern going forward within when it comes to innovation?
Yeah, I think it's highly dependent on the use of that device. And so when you're talking about a robot that is being used to assist the elderly in different exercises and things like that, I think it makes a lot more sense for the user to be controlling the robot in a way with their motions. Sometimes you need the robot to be more automated and to have more functions on its own, and it kind of depends on the application. So if you're looking at, for example, an infusion pump, which is not really a robot, but essentially it's an automated device, when you're looking at something like that, you want it to be able to be programmed to do something, but then automatically change as it senses different parameters and things like that in order to, one, reduce the workload of whoever is utilizing such a device, but then also to optimize efficiency and minimize errors and things of that nature. For a robot in the operating room, you need the surgeon to be able to fully control the robot. And it's not necessarily automated by what the surgeon is doing, but that the surgeon tells the robot exactly what it wants it to do because it's such a high risk environment, life and death in the operating room. And so I think that it highly depends on the use case for that robot and understanding what would optimize efficiency, safety, and decrease cognitive workload in that setting.
I guess as a follow-up to that response, which is very detailed, so thank you for that. I know that with new technologies, especially with CRISPR and things like that, you can get down to the DNA level, which is amazing. But the question that I have is when it comes to, you mentioned this earlier too, cost as versus efficacy or efficiency. Can you talk a little bit about that, and especially how you see artificial intelligence is playing a role in all of that?
Yeah, so there are some aspects of healthcare which can be very much automated. So there are some things that we understand extremely well. There's some human physiology that has been tested and tried for many years, and we understand that very well. And so putting in automation and having potentially a higher cost device that implements AI and really works to manage the patient on its own in order to decrease the nursing time required, especially with staff shortages and high staff turnover these days, very important to be able to optimize nursing workloads. And so in that sense, having a higher cost device makes a lot of sense. If you're applying it in a different area where there's not such a cost benefit or value to the patient or to the setting, I think it makes a bigger difference that you have a low cost device where you're not having those types of issues. Trying to minimize the automation in the device, minimize the complexity of that device so as to be applied appropriately.
Just an announcement really quick. There is a red vehicle outside that is about to be towed. If that is yours, you might want to head down there and get that taken care of. Right.
You don't drive a red car, do you,
I
Monica?
do not.
My question is partly related to your work at Wavemaker 360 Health, the venture fund, but also related, of course, to your work in human factors. You just talked about efficiency, having trouble finding enough people and that kind of thing. We've got a larger population. The ratio between healthcare providers and people is not something that is holding steady, as it were. And then another thing that one of your partners at Wavemaker mentioned is that productivity in the healthcare space has not kept up with productivity in sort of general industry. And there's a lot of really good reasons for it, and then there are some that are maybe not as good. So the question is what are you seeing out there in terms of productivity improvement? How much are people investing in it? Is this an area that people are really particularly founders and co-founders and entrepreneurs are really targeting given the need? And, sort of just general comments about that, including, do you believe that enough people know about this very fundamental problem in healthcare?
I do think that there is a lot of awareness about productivity issues in healthcare, staff shortages, staff turnover. The awareness is definitely there. The solutions, I think, are more difficult to come by, and that's why there haven't been as many productivity gains. There's some companies that are focusing on that, and those companies are actually making a lot of progress and getting a lot of traction. But I just don't think that there's enough companies working in that space. So I do agree with you that it just has not kept up with other industries. And I think there's a few reasons for that. One reason is that it's healthcare, it's life or death. And so things that could be automated in other situations, in other industries, are not things that people are willing to allow to be automated at this point, because if there are errors, one, the errors are very significant in life and death in nature. And two, even a small number of errors is a huge issue. And so there are difficulties in implementing AI and other things that allow for productivity gains in healthcare that I think are very difficult to solve for in a lot of the circumstances. There are circumstances where they can be solved. We've seen like these robots that are helping with like simple nursing tasks and delivering medications. We've seen infusion pumps and things like that, which kind of automate some of the manual programming that nurses have to do. But other things that could be automated, like medication administration or things like that, very difficult to automate that in a way that you could confirm that patients are going to be safe, and safety is the number one priority there. So I agree with you, productivity gains are not the same in healthcare as they are in other industries, but there is a major reason for that.
Good morning. Thank you for your presentation. It was terrific. My question was about, certainly appreciate the work you did around human factors, workflow. How do you intersect that work with regulatory regimes and kind of the other constraints that are so dominant in healthcare to figure out kind of what's practical and how to get those into in practice?
Well, for me, I think the most practical thing is making sure that when you're starting a company, that there is a real need for whatever product you're making, and that there will be adoption of that product in the long run. So even before understanding what the regulatory process is, what the reimbursement is, if you can't get a product adopted or there's not a significant need for it, or it's very difficult to implement into a physician or nurse's workflow, then the rest of it kind of doesn't matter. And so I think the early discovery, especially with programs like the NSF I-Corps, where they pay for you to do 100 people, of 100 companies, 100 people, 100 patients, whatever it may be, of discovery, make a big difference in that early stage development and kind of solidifying the concept for your device, solidifying the initial use cases and things like that. From that standpoint, obviously the regulatory hurdles are significant, and understanding what clinical trials are required, and helping those clinical trials move as smoothly as possible by doing all the work at the front end for optimization also makes a big difference. And so I think that human factors is actually one of the earliest things to consider when you have a healthcare or really any startup with a product that's going to be implemented somewhere for other people to use. And then from that standpoint, you can pare down some of the functions in order to simplify your regulatory process and kind of ease your timeline in the long run.
We have time for two more questions. But before I do that, I do want to give Andy Wilson an introduction. He is the founder of Friday Coffee Meetup. And a lot of people thank me for helping to organize this, but he's the one that is responsible for bringing this group together. So please thank him afterwards. And next question.
Yeah, I love this subject. I find it very, very interesting. My question is around the surgeon. As you change technology usage, you were talking just about the gloves and the hand size. Is there part of this protocol, is there any research on physical training for the physician? Like now that they're sitting more versus standing versus sitting, going back and forth. So I'm just curious, is that part of your research or protocol, sort of prepping or physically training the physicians?
So until the pandemic, there was almost nothing. There were some guidelines from the robotics companies or the laparoscopic companies on how to optimize where your monitors are positioned, how you should hold your instruments and kind of optimize that positioning, or for the robot, how to sit properly with your arms at a right angle, your feet at a right angle, etc. And they made the robot console adjustable to allow for that. The pandemic really brought about a huge focus on physician well-being, nurse well-being, and that has really revolutionized what we're able to do in terms of leadership acceptance of training programs and focusing on how we're able to help the physicians in that area. So now there's been a huge boost in understanding ergonomics and positioning, providing training for our residents and medical students at the very earliest stages to position themselves properly, stand appropriately, adjust the console as you need, etc., in order to minimize work-related musculoskeletal disorders. Because until the past 5 years or so, there was a awareness that a lot of people are hurting, a lot of surgeons are hurting, especially. But there wasn't really a focus from the leadership to be able to fund those and support those types of programs. So there's been a big change in the past few years, and we're really glad for it. But I mean, just as an example, many of my mentors throughout my surgical training had C-spine surgery, had lower back surgery, operated when they were in significant pain, just ignoring it because that's a culture in healthcare. And so I think that the last few years have been a big improvement for the culture in healthcare.
Hi, so thank you so much for coming. That was an amazing presentation. My background is in tech and more specifically data. And you had quite a lot of data in your presentation. A couple slides that were interesting. Of course, for robotic assisted surgery, you mentioned the benefits, better outcomes, better patient recoveries, but you actually had a question mark next to it. So my question is on the data behind where you see those better outcomes and whatnot. Who's responsible for gathering that data? You talked about your CS Insight team there. And do you have both an internal team at Cedars as well as external teams that validate those the better outcomes and all of the data behind that?
Yeah, so in healthcare, people are actually very focused on patient outcomes. And so there are many people out there who are doing this kind of research. We have many databases, which include all patient information, the NCCN, which is the National Comprehensive Cancer Network, the American College of Surgeons, many other societies have databases that allow input of all of the data related to patient diagnosis, surgery, outcomes for cancer, when they recurred, in what way they recurred, what treatments they had, et cetera, et cetera. And so there are literally thousands of publications that have been done that look at open versus laparoscopic, laparoscopic versus robotic, open versus robotic, what the patient outcomes are, the immediate complications, 30-day mortality, long-term cancer recurrence, long-term quality of life, like literally thousands. And the majority of these publications are demonstrating in certain areas, as I mentioned, prostatectomy, that there is a significant difference in outcomes with robotic versus laparoscopic or open surgery. But the rest of the applications, for the most part, studies are either inconsistent or non-significant in terms of the benefit of robotic versus laparoscopic or open surgery when it comes to all of these different things. And so it's actually well validated by data that's done across the country by researchers and all and clinicians actually in all of these different areas. And same for like ergonomics. We've done a lot of studies. We internally as well as externally. I'm a founder of the Society of Surgical Ergonomics, and so a lot of my colleagues at different institutions have also done studies about ergonomics and surgery and understanding the rates of pain that are reported, where the pain is reported, how much pain they're in, what interventions they've had for that. So healthcare is actually a very data-rich environment when it comes to that. And if you truly look at all of the data, the benefits of robotic surgery don't quite play out the way that they were touted by the company itself. So great marketing, not so great on the other end. But I do think that there's room for there to be more benefits of robotic surgery with just, some changes. For example, doing more ergonomics training for surgeons who are going to be sitting on the console to minimize the ergonomics issues that have changed where they're having pain between laparoscopic and robotic surgery. So there's some work to be done there still.
We do have a couple more questions, but unfortunately we're out of time. So